The Jerry Pal podcast is brought to you by Archstone Foundation. Archstone Foundation, improving the health and well-being of older Californians and their caregivers.
And supported by listeners like you, many of whom have donated on the Jerry Pal fundraising site, which you can find at www.jerrypal.org, big blue button, or through reviews, stars on your favorite podcasting app. Big thank you. Welcome to the Jerry Pal podcast. This is Eric Widera.
This is Alex Smith.
And Alex, we actually have somebody in person, but we're doing this virtually because of COVID. Who do we have virtually in person with us?
We're all in the same hallway here, but we're recording from different computers so we can record on mask and have high quality audio for you, our listeners. We're delighted that Kate Courtright is here from the University of Pennsylvania. She's an assistant professor there. She's trained in pulmonary critical care and palliative care. She's a palliative care researcher. She's also a member of the PARE Center, which stands for Palliative Advanced Illness Research Center. And she's here as a visiting professor for the day at UCSF. Welcome, Kate, to the Jerry Pal podcast.
Why, thank you, Alex and Eric. This is an awesome opportunity. I have had such a great day so far, capping it off with this.
We got a ton to talk about with you, Kate, about palliative care, research into it, lots of who's, what, whys that we'll be talking about. But before we do you have a song request for Alex?
I surely do. So I'm requesting Tom Petty's Running Down a Dream. There's a little reasoning behind that today. So I'm in San Francisco for both this visit and the American Thoracic Society conference. And it just so happened to overlap with the Beta Breakers very famous 12K race that I got to do on Sunday. I dressed as a unicorn. You can see me on Twitter. Ran with a very good friend who I hadn't seen in years, Carrie Quill, also the daughter of Tim Quill, well known in palliative care. Carrie and I trained together at Penn. It was wonderful to catch up. We are both runners from childhood, so we sort of reconnected at our roots. And it was an experience. I'd never done it before. As I shared with Alex earlier today, I saw all sorts of things, and some were good and some were not so good.
Some things you can't unsee.
There are some things you cannot unsee, as I learned.
Welcome to San Francisco and the Beta Breakers.
It was great. And running's just a big part of my life, keeps me very balanced. I just started ultra running, which is a very California thing. So yeah, I'm excited. So running it is.
Great. Here's a little bit of Running Down a Dream by the late, great Tom Petty. It was a beautiful day. The sun beat down. I had the radio on. I was driving. Trees flew by. Me and Dell was singing a little runaway. I was fine. Yeah, I'm running down a dream that never would come to me. Working on a mystery. Wherever it leads, running down a dream. Woo!
Nice, Alex.
Thank you.
Love that song.
Yeah.
Love Tom Petty. Thank you.
So, Kate, maybe we can start going a little bit farther back. How did you get interested in palliative care research and the stuff that you're doing right now?
So it was a little windy path. I was always critical care bound since medical school, but definitely sort of always had the bug to be the one to jump into the family meetings in the ICU, lead them, constantly like observing the good, the bad that I saw when others were doing it. And palliative care as a program was just growing at Penn, moving sort of from just consult hospice to actually having a team when I was training. And it's interesting to look back. I have never myself called a palliative care consult as a trainee because we didn't have one. They were at the VA, but not so much at our main hub hospital where I trained. So when I was in my last year of pulmonary critical care fellowship, we had 2-week elective, and I was studying advanced directives in renal disease as my master's thesis, a little bit of a diversion. And I sort of kept saying, I want to do end-of-life care research with Scott Halpern. And that's what I did. And I started to realize in that 2-year process, boy, running this RCT is awesome and I love my team, but I don't really love advanced directives. And so I took a palliative care elective in my last 2 weeks of fellowship with Nina O'Connor, an amazing mentor and clinician, and just fell in love, realized I had both missed the boat a little bit clinically, and it was clearly going to be where I wanted to spend my time doing research and sort of bringing more palliative care to the living with serious illness instead of dying from serious illness population. That just kind of sparked me a little bit more. So I took on 2 years of sort of an apprenticeship model at Penn. I'm training with the fellows, but not really being one because I had grants, and it was an interesting couple years. But here I am many years later with an exciting research career, and I practice both on the palliative care consult team and in the ICU. So I'm kind of right where I wanted to be.
And your research as a critical care doctor and a palliative care doctor is not just on palliative care and the critical care unit, right? You're looking at a lot of different things.
Yes. I think that palliative care in the ICU is an absolute important area, but I just, for some reason, have always come at it from a even further back 30,000 foot view of all serious illness, cancer, non-cancer, not just pulmonary, non-cancer, even as a pulmonologist, not just in the ICU. I do tend to focus in the hospital setting. It's where I practice. It's what I know. But yeah, I sort of take a broader approach.
Mm-hmm. Now, you gave a talk earlier today, and you talked about how there's been an explosion in growth of palliative care in U.S. hospitals, primarily in the inpatient setting, but that there's the large majority of evidence for palliative care is actually in the outpatient setting, where palliative care programs are not as well developed. And I know you're very interested in clinical trials and pragmatic clinical trials. Could you share with us more about how you got involved and what you see the need is for clinical trials of palliative care, particularly in the inpatient setting?
Sure. I think where I was talking today about where the need is from an evidence standpoint is the field before me. Many people in the field worked really hard to get at efficacy and show sort of improved outcomes from palliative care. And then it kind of stopped there. And I taking a bigger step back and looking at the population in the hospital or population in the ICU, wanted to sort of say, okay, if we can do it in this really controlled way, where we have all the levers and we know exactly what we're delivering and when and to whom with this very narrow population, that's just not how the hospital works. It's this really busy, consults it's all over the place. Patients have all sorts of problems. And does it work if you just pick it up and put it into this complex system and open it up to everyone who may be appropriate? And that's where the real world pragmatic sort of I came from. Can we move from efficacy to effectiveness and still see how we can improve care? It's challenging, but I think that's the only way to sort of scale up what it is we need to do.
Mm-hmm. And for those listening, many of our listeners are not researchers. And I think you did just explain this clearly, but just to, say it again, if efficacy is different from effectiveness, and that efficacy is when you test something right in more of like a highly select controlled environment with people who are very likely to respond.
Right.
And effectiveness is when you test something in real world settings.
You just embed it into routine care and workflows, and you really aim for a broader population, outcomes that are routinely collected, care that can be provided in the course of routine care, and not trying to sort of manipulate and control all of the factors, because that's just not how it's done in the real world. Mm-hmm. Exactly. But you sort of have a trade-off, right? Because you still want to have some selected population that they're likely to benefit, but you want it to be broader. And so you tend to see maybe less effect, but you've affected a broader group, as opposed to a greater effect in a very narrow population. So there's a trade-off. There are
trade-offs. And you actually criticized, prior studies. Well, I mean, your own probably included, where people attempted to leap too quickly from the highly controlled environment of an efficacy study to like the broad-based, does this work in real-world settings, and then find out, well, no, but there's probably because there's a huge gap in the way that it was implemented.
Yeah.
And so many lessons that were missed along the way. We tried to jump from A to Z and skipped all the letters in between.
So I missed the talk. So you got to tell me, like, can you give me an example of one of those?
Yeah, and it is, it is my own work. Criticize is strong, but I call it lessons learned. I think that implementation research as a field, implementation science, has become incredibly forefront and clearly needed. And maybe it just got a great name. And so now we're all recognizing its importance. But what I shared is, the paradigm of research has gone a little backwards. We all focused on studying the outcomes for patients and families of our intervention and then the processes to get there. Whether it's the consult rate or documentation of a conversation, hospice referrals, those kinds of things, and then patient outcomes, quality of life, symptom burden. But when you take that from a sort of small efficacy, explanatory, traditional randomized trial and say, my thing works. So we more people need this. So we're just going to, put it in the hospital or my entire clinic or what have you. You should all take this up. You all of a sudden uncover all the ways in which the real world needs to be looked at a little more carefully. We work in an incredibly complex system. And so what are the components of the system that implementation of your efforts and your intervention are going to work well or not work well? And that can be things like sustainability, acceptability, maintenance, appropriateness, which I know hopefully we'll get into, and many, many more. And so what the implementation science field has really shown is you should be designing for implementation from the jump. So your intervention design, your efficacy trial in a small setting should have implementation in mind. And I don't think we all realized that early on. We just sort of designed the ideal thing and then tried it. And instead, implementation should not be at the end. Like dissemination, implementation research comes later. It should really be integrated early on and be a key part of the research along the way of getting towards a scalable, effective intervention. So we have a little bit of backtracking to do with sort of what I was sharing. Very much my own work included.
And I know that I mentioned the word pragmatic trial before. And I just want to give the opportunity for you to explain to our listeners, what is a pragmatic trial for those who aren't familiar with that term?
Yeah, I mean, we touched on a little bit. It is sort of a rigorous, randomized, high quality study or evidence generation, but really taking what's happening in the real world and trying to mimic that as much as you can in every aspect of your design. So your population is more broad, your intervention might have to be a little bit less ideal and perfect and modified to work in that real world setting, the outpatient clinic and how that's going to work, or the hospital. Your care, the intervention delivery is by who's in practice. You're not hiring trained facilitators. You're not hiring bunch of social workers or nurses or docs to do it. You work with who's there, and they deliver care. It happens in the course of routine care. They don't come in for additional visits for your intervention. Adherence, fidelity is looser, which is why it is lower often. Adherence to the intervention is often lower in pragmatic trials. You certainly don't want it to be very, very low. That was something that happened in the Proven trial with Susan Mitchell and Vince Moore, not for lack of trying, but they had a really hard time getting their intervention actually to the bedside. So it's hard to then study what happened with it if many folks didn't get it. So
the Proven trial was that the video?
The nurse in the nursing homes. Yes. And while they identified, thousands of patients and enrolled, actually having the video shown, and viewed was very low. I think less than 30% by recollection. I'm sorry if that's incorrect, but pretty low. And so it's not that we can't then look at the effectiveness, but you do wonder, like, what am I really concluding about this? Not to wade into the ACP controversy. I definitely don't want to do that today. But
we go there frequently.
Yeah, but
we don't
so
have to go there.
Adherence to the intervention is more flexible. You might support the team. You're there for check-ins, but you're not, training on fidelity and high. It's just not quite. The other thing and outcomes are collected in the course of routine care. You're usually not soliciting, thousands of patient-reported outcomes. You're collecting from the EHR or what the clinic already collects from databases, admin, claims. That's purely pragmatic. And then there's purely explanatory, I'm controlling everything, your placebo versus medication trials. The real research is in the middle. It's really hard to design a pragmatic trial that's truly pragmatic in every domain. And it's pretty hard to have an explanatory trial in palliative care that isn't slightly pragmatic somewhere. So It's actually a spectrum, but we kind of talk about them like they're vastly different.
Mm-hmm. The title of your talk earlier today was, let me just pull it up, Improving Palliative Care Delivery Through a Precision Medicine Lens. When you say precision medicine, I'm assuming that you're saying that we in palliative care, we should be drawing more blood and sending it off for specific biomarkers?
I know. It's, maybe we can call it personalized medicine. That's a new hot term, right? This has just been at the foundation of my research since I started in palliative care. I had to think about the way I was interested in palliative care delivery, clearly. And this was just sort of grabbed me when I learned about the field strain of supply demand for clinicians and specialists. And it seemed like the solution was more consults. We need more consults. And we want a consultant in the ICU embedded, and that clinic wants a consultant in the ICU or in their clinic. Everybody needs more a specialist, but that's just not realistic as a hammer solution to everything. And I just started to unpack but there has to be a better way to know we are a complex intervention, whether it's specialist or even primary palliative care, right, delivered by the treating clinicians. It's still complex in terms of what we're delivering. And so do all seriously ill patients need all components of palliative care at all times in their illness? Or can we start to ask sort of who's most likely to benefit from which components of palliative care, because there are many, and when optimally and where optimally, and then how do we do that? How do we deliver that in a sort of value health system supported based way? And that's sort of been the structure, the who, what, when, where, and how that I apply to really any question, like the micro question of small population, single setting, or the macro, like how do I deliver this in the entire health system?
So let's break that down for our audience and me, since I wasn't at the talk. What's the who?
So the who is identifying patients most likely to benefit from, and I'll say palliative care, but it could be sort of your intervention, whether it's supportive care or a social work intervention-led intervention, an ACP-led intervention, whatever it may be. So I think of it as predictive enrichment, the idea of enrolling patients who are most likely to benefit from your intervention and being smarter about how we identify those instead of, say, all patients with X disease who have an FEV1 of whatever, or all patients with cancer, or so really being a little bit more what we call predictive enrichment in clinical trials to increase the likelihood of benefit, but also minimize risk of harm from treating people who wouldn't otherwise benefit and minimizing risk of using a scarce resource inefficiently.
Right.
So what do you think the best way is? Because I think a lot of teams are trying to figure out, like, how do we decide or define which patients we should see? And also, how do we target specific groups? Should we just use the referrals, whatever is coming into us, whatever clinician decides? Should we have like a list of diagnoses or prognoses? Do we use what else? What do you think we should do to identify patients?
Softball question. Thank you, Eric. It's like you did attend the talk. So you nailed it. I think we're done here.
I listed everything, so hopefully
we're done. Obviously, the usual care, what happens, day to day is clinicians refer patients to palliative care, and that works. Clinicians largely know sort of sick, not sick, and they have a sense about their patients. Maybe they overtly ask, but there's some downsides to that. I tend to use the word haphazard. And in a paper I wrote a long time ago with Scott Halpern, my mentor, about this idea of the who, what, when, where, how for palliative care delivery. We talked about this haphazard approach, like it's clearly led to likely inequities. We know we've seen that in palliative care research by many other wonderful teams. Biases, implicit biases clearly play a role in practice. Competing tasks, like clinicians are busy and have really important things and metrics they have to do. And so palliative care falls down the list a little bit. Like that's not very patient-centered way to deliver this really important resource if they need it. And so it's not that clinicians should be removed from the equation. No way. And none of our work does that, but they need a little bit of help. They need some, a little bit of information, and probably a little more than that, what we like to call a nudge, because we know information provision. I think it was the support trial, like even giving them information about poor prognoses didn't change their practice. So we have to do a little bit more to support our clinicians in identifying who's likely. And that's where things like diagnosis triggers, if you will, prognostic triggers, and then the ideal need-based triggers, where I think the field would all love to go. But we just haven't scaled that yet. We can do that in a small clinic for a handful of patients, but there's no real system and systematic electronic way to identify need-based palliative care right now.
Yeah, I'm thinking of our own practice here, Eric, and we have entirely a clinician referral-based practice, I believe, right?
Yeah, we have no triggers in our practice. It depends on the referrals. And honestly, I think we have high referring physicians and clinicians, and we have low referring ones. So it depends on who's on service, I think, as well. Our outpatient service does have guides around diagnosis and prognosis. I think need is hard without any of those other things. Like, how do you because we also have, we have a pain service here, integrated pain service. We have palliative care, who gets what goes where. That gets really complicated as well.
It gets very local and individualized, as you were saying.
Right.
What the needs may be in one institution, when you go to need, palliative care may be best for, some needs, but it may be that other services at some institutions are better for other needs.
That's right. And I actually think the cool thing about a needs-based approach would allow us to better utilize the service. We are a multi-interdisciplinary group.
Yeah.
How do we best utilize the sort of power that we have in a really efficient way that allows us to reach more patients where they are and what they need?
Right.
But we can't do that if we just very crudely identify patients, even with things like by diagnosis or prognosis. They're still pretty crude correlates for need. But I do believe they get us a little closer to at least overcoming the sort of lack of systemization, access. We talked today, it doesn't fix the geography access problem, but within the same, you just said, within a clinic, depending on who's on service, is who gets palliative care. That's a different kind of access problem for patients, and that can be fixed.
What would a need-based service look like? What does that look like?
I don't know. I think we'd have to all decide. I've always conceptualized it in the National Consensus Project's sort of 8 domains. I don't know if that's real actionable, but some version of sort of domains of need that make clinical sense. Maybe there's psychosocial needs because you sort of know, maybe I know what I could do about that, or there's physical symptom needs and there's psychological symptom needs. There's end of life care needs. That's sort of how I've conceptualized it, but because we've not operationalized it, I don't actually know if that's what it'll look like.
Mm-hmm. Yeah. It's more aspirational. I wonder, going back to, this is fascinating, we can unpack each of these. If you move away from the clinician-based, on the one hand, you were saying you don't want to take the clinician out of it.
I don't think patients want that either.
And patients may not want that. And I imagine that you probably would get pushback from clinicians. I'm remembering at another California institution, they instituted palliative care triggers, auto consults.
Oh, yeah.
And they got pushback both from the the teams for whose patients were automatically, generating palliative care consults, the hospitalists, the attending physicians on those teams were like, "What? I didn't know this was. Why is this happening?" What?
Yeah.
And then on the other end, you had the palliative care clinicians. Sometimes they felt like, "Oh, good. I'm glad we're seeing all these patients," but other times they said,
This wasn't really appropriate.
yeah, it wasn't really appropriate. I'm not sure why we're seeing, every single patient with X condition.
Agreed.
Yeah.
And that doesn't help our strain problem. Like if we just open the floodgates, I think, we're obligated to do that in a smart way. If we're going to systematize it in terms of at least, we can quibble about what the best way to identify, but I think we all agree it should be more fairly offered to those we think would benefit, however that may look. But we can't open those floodgates and not consider the strain and the sensitivity and specificity trade-offs, if you will, of whatever that trigger is, have a real impact on the palliative care clinicians.
Mm-hmm.
So then there's the question of who is going to get it. And then you also brought out the when, what, and where. So when should palliative care? Is that distinct from who? Like when in their disease course or when in their, how do you think about when?
That's a good question. Less of a softball. So when is, you guys know, it's early. It's early. Just early.
Like
That diagnosis early. And that's sort of my pet peeve with the when is we've said that for a long time. Earlier at diagnosis. But what does that mean? There's like millions of patients with COPD. Like at diagnosis? I don't think so. Or do they even want it? Is that appropriate at diagnosis? Certainly probably not specialty for everyone. Palliative care, maybe primary palliative care. So I think to your point, the when, even the where and the what, I had this diagram, had you attended the talk, Eric, with all of these bidirectional arrows, because no, they are not in isolation. Oh, if we just knew who, then I can figure out. The who and the when and the where and the what are probably all interrelated. So the COPD and metastatic cancer patient has a different, I'm arguing, might have a different when and where and what. And we should figure that out in some empiric way. I think we all have a sense that it's different, but how? Like, let's study it and figure it out, and then tailor interventions and study them that way, at the optimal time. And I think we can do that empirically.
Yeah, I guess one question is brought up. We had a previous, I think it was Vicki Jackson. We talked about all these, randomized control studies, even looking at lung cancer versus colon cancer. Maybe there's a difference. Do we have to do a randomized control trial for all these different diagnoses? But this also makes me think, how important is it the diagnosis or like the overall theme of what's going on and the kind of the need issue, kind of going back to what you were saying before. Yeah. It's not really the diagnosis. I mean, it just reminds me of like the JAMA, for chronically critically ill patients in the ICU. Should we have palliative care visit once, deliver a prognosis, and then leave? No, that's a horrendous idea. It was negative, maybe increased PTSD symptoms. It was the wrong intervention at the wrong time for the wrong people. And like, should I be thinking about this as far as, should this be based on diagnosis? Should this be based? How do you even think about like running these trials and figure out who gets what, when?
I think
I asked 17 questions right there.
No, it's okay. You hit it though. We're back to why need would be so aspirational. I don't love that we sort of, I'm going to say, pit diagnoses against each other, because I have to be honest, I think that the chronic life-limiting illnesses, non-malignant, are going to lose out. Especially palliative care is just going to get further shifted towards oncology if we study it that way, because of the trajectory of those diseases. You've all seen those curves. It's a prolonged chronic step down. Intervening is almost harder to know when and where in those course of illness, as opposed to the beautiful study by Jennifer Temmel in non-small cell, lung cancer, in which it was like at diagnosis, and then there's this clear trajectory. And so I don't love diagnosis-based approaches. I understand why we do them. They are easy to identify. It's something you can just very specifically and accurately know. And that's why in the talk I gave it as a spectrum. It's like clinician, haphazard, bias, disparities, not so great, but they're an important component. Diagnosis, still pretty crude, definitely doesn't correlate with need. We've shown that certainly in pulmonary disease. Even if you say advanced, the sick, you look at their physiology of their lung disease, their symptoms don't correlate all the time. And then prognosis, I think, gets us a little closer. Alex and I and others talk about it's not the prettiest story to talk about prognostic triggers. It gets conflated with end of life care. We're just shifting, palliative care towards everyone who's dying, but prognostic models don't just identify dying people. They identify people who are really, really sick and at risk of death in some time frame predetermined. But nevertheless, it's a hard thing to sort of talk about and implement for that reason. And then need, it would be amazing. And I think we should still work towards it. I'm not saying it's aspirational and we've given up. It's going to take a lot of work to really make it operational on a systems level. So I think as long as you justify, my thing is just justify how and why you're identifying your population and why they're likely to benefit from your intervention. And I think as long as we do that, then you can feel good about your match to intervention.
And do you think there are things that we can, if we identify a population of need, do you think there are things that we can do to increase access or referrals from that population? Like, are you guys doing anything in particular at Penn around this? I know one thing we're doing in clinic is obviously oncology is an area of palliative care knows a lot of need in. So we attend oncology huddles, like FaceTime. That's really going towards the clinician and trying to increase referrals. I think you're also doing something interesting around nudging. We also had a great podcast with Scott Halpern not
Jenny.
Too long ago on that. What do you think about that?
That's a lot of where my pragmatic trial research is going. If you look at there's like a development and progression in my learning through my trial designs. And my first one, in hindsight, was a diagnosis-based trigger, and we didn't even call it that at the time, Scott and I. It was. And then our next trial was still diagnosis, but we pulled in severity of illness to kind of get at that was an ICU-based trial, but we both identified people with diagnoses, but also a severity of illness that was quite high in sort of getting at correlating with poor prognosis. And then my third trial, which is something I'll be launching at Penn, is leveraging a prognostic model for 6-month mortality in our 6-hospital system embedded in the EHR. And we sort of did pilot work and chart reviews to say what threshold sort of says you're sick enough in the hospital, and we won't, annihilate our palliative care team, sort of finding that implementation balance to trigger a nudge in the EHR for, again, moving away from just triggering specialty palliative care, which we've done in past trials, and is important, but really trying to get towards this collaborative integrated model where we nudge primary palliative care. But it's up to the clinician. And if that doesn't feel appropriate or they prefer the specialist, the nudge also nudges specialist if they're choosing not to provide primary. So consider something, basically.
So a nudge. So I think about a nudge, if I'm remembering correctly from our last podcast, which we'll have a link to in our show notes, is something that pushes people towards a particular direction, but it's not a forced choice. They can choose something else, like changing the default. What can you share what nudges you're using?
Sure. So you're correct. There's a hierarchy of nudges, if you will, that I'm sure Scott and Jenny talked about, where you more strongly push at the trade-off of autonomy. And that, once you say it that way, right, clinicians don't really like losing autonomy. And you already gave a wonderful example, the automated consult. It's not going to work. You can't take away the bedside clinician's autonomy. They have a lot of information and good knowledge about that patient, but you can nudge them to have the final autonomy to consult or to do it themselves. But they can't unknow, as I said, you can't unsee what I saw in Beta Breakers. They can't unknow that you told them palliative care is recommended for this patient, and either you should do it or you should call experts, or you should have a reason why you know better. You think this is not appropriate, and no judgment. There's no penalty for saying no thanks, but they can't unknow it. So it does work, and so defaults work. They increase consult rates. That's with an opt out. Hey, a consult's been ordered. It's not active yet. You can cancel it, but here's why. Yeah. And then they either cancel it or they don't, and it becomes active. It works. It increases consult rates. We can try, we've tried things like accountable justification, which I really like. It's this idea that as clinicians, we all have reasoning behind our medical decision-making, and we're accountable for that, all of it. Right. And so it's within normal practice to have a reasoning and be accountable for it and document that, because that's what we do. And so in the EHR, you can say, have you done this practice that's recommended? So palliative care for this sick person. If they say no, they say, and why not? And they offer a free text reason why not. No penalty, just offer why not. If they say yes, you leave them be. They've done the thing. So just being accountable for that you've done or not done the recommended practice, and justifying why is actually quite powerful as well.
And I'm guessing there's also it's less effort just to say, sure, just do it, rather than having to type something out.
Yeah, some clinicians may find the path of least resistance. I'm really busy and I'm fine with it, and I think it'll be fine. And others have on occasion written some really not nice things in their text justification.
Yeah. And potentially the social norms. Most physicians would call palliative care at this point.
Exactly. Social norms, yeah. Right. Most patients would, or most clinicians would do that. So all of those are, they don't restrict autonomy, but they are effective in certain cases.
Is that, are you using multiple nudges in your Ponder ICU trial?
So the Ponder ICU trial did use multiple nudges. We just finished enrollment during, the height of COVID for that. That used accountable justification, and it used a focusing effect where we leveraged the very natural tendency, especially for ICU clinicians, to be highly focused on specific things. And instead of only being focused on the mechanical ventilation parameters that day, we force them to focus on prognosis. They don't have to share it. They don't have to discuss it, but they have to think about it. And we do that by just asking them about it. What do you think the likelihood this patient survives over the next 6 months? And if they do survive, what do you think their functional limitations may be, from bedbound, moribund to totally fine. And there was some really amazing work by Allison Turnbull at Hopkins and others that showed just having clinicians focus on prognosis and, moving them out, taking the blinders off, if you will, and focusing on something else, changed their willingness and likelihood of discussing recommended practices in critically ill patients likely to not survive, which are recommended by many of our professional societies, which is to share and discuss prognosis and to talk about alternative options to continuing aggressive care. And just having the discussions, not making certain decisions a certain way, but sort of improving communication practices. And clinicians were more likely to do that just by focusing on prognosis. So these silly little sort of harnessing all of our internal biases and mind tricks that we do to get through a busy day can be really effective.
I want to ask one question. I know we're running out of time here, so this is like a huge area. Yeah. But in sort of a quick way, could you let us know what do you think the key outcomes should be?
Oh, Alex.
I'll make more time for this question. I want to hear
There's 3 minutes.
Of the palliative care trial. Like, what are we aiming for here?
This feels like a setup.
Out of time. No, I'm just.
Yeah, right. Thank you for the opportunity today. So where I've landed after not nailing it in my first 2 trials, I just fully admit, is I wish we could get away, scientifically from I need a primary outcome. I feel like these trials have to have stories of outcomes. There have to be process outcomes. There have to be, if possible, patient or family reported outcomes would be ideal, even if it's in a subset of a pragmatic trial, which we're doing in our next trial, because it's just so important, even if it makes it slightly less pragmatic. Like I said, a spectrum. traditional clinical outcomes that are important to health systems and hospitals. Like, I know it's icky, but we got to talk about it. That's how we keep practicing. It's how we get to do what we need to do. So you need sort of the whole story. In addition, you need the things that help you understand if palliative care consults or primary palliative care can result in things that we don't know if they were patient-centered. Comfort-focused care in the Ponder trial was an outcome. And was that patient-centered? Was a good conversation had about that? And so sort of like understanding what went on and trying to get at that is where the process outcomes come in. And then qualitative, like I lost some opportunities to do really good qualitative work as trials are ongoing. Once you get the quantitative data, if you understood sort of what was happening along the way qualitatively with different stakeholders, it might help you interpret that slate of outcomes. But I am just totally of the notion that we don't have a single outcome and likely never will. We're too complex of an intervention for that.
Yeah.
I know that was a dodge.
No, that was a great answer. That was a terrific, time-efficient answer.
I got one more question. As I know you're not a self-described trialist, but I'm going to call you a trialist, thinking through, and you even mentioned about, we have a lot of evidence for outpatient palliative care, great randomized control trials, some inpatient, and we keep on bringing up primary palliative care. Mm-hmm. We've had several episodes on primary palliative care interventions that have been negative. One large one in nursing homes doing primary care. We had another
infusion centers for patients with cancer.
Do you think we have evidence? We keep on mentioning for primary palliative care. Do we think have we figured out how primary palliative care even work? Because like they're in a system that really gets the results that it gets because it's fragmented, it doesn't work, and just trying to teach somebody or get champions doesn't seem like it's working.
Yeah, I think that's a tough question to answer from a does it work in general perspective, only because you're comparing like apples to oranges to pears to bananas to steak. If you look at the primary palliative care interventions, no two are alike.
Yeah.
And they're all quite small studies, mostly. I can't say that, with certainty, but we know there aren't massive, large palliative care trials out there. And so I don't know if it works. It definitely, we haven't even really defined what primary palliative care is, honestly, right? So I don't think we can say it works or doesn't work because we haven't studied the same thing over and over. We keep studying something different. And I understand why. And I think people have tried to tailor what they believe primary palliative care to be to their setting or their population, but we're back to not really knowing then what works because we change it every time. And we've not done it in a broad, large population.
I also feel like it's just kind of holy grail thing. Oh, like we will never have enough private or specialty palliative care.
Train them up.
So let's just do this primary palliative care thing. Like, you do this thing, here's some time to do it. Like that'll solve our workforce issues. Right. We're not very specific what we mean by primary palliative care. Right. And we don't have really good evidence on what really works when we think about primary palliative care.
Well, I don't know if you've noticed, but most of my work is in specialist palliative care because I find the primary palliative care problem so much harder. I think smarter people should solve it. I like to tackle complex problems, but that one has just eluded me. And I think smarter people are working on it. So I stay in my specialist palliative care lane mostly.
Yeah. Well, I love that you're working on a mystery, going wherever it leads.
Yeah, maybe we can just run down this dream of primary palliative care.
I felt so good, like anything was possible. I hit cruise control and rubbed my eyes. The last 3 days, the rain was unstoppable. It was always cold and no sunshine. Yeah, I'm running down a dream that would come to me, working on a mystery. Wherever it leads, running down a dream.
Awesome. Thank you so much, guys. This was fantastic.
Kate, thank you too. Unfortunately, we're all in the same place, but not in the same place. Next time when we have you on, hopefully we'll all be in the same place.
I agree.
Very big thank you for being on the podcast with us.
Yeah, thank you. I'll see you in 3 seconds.
And thank you, Archstone Foundation, for continued support. And to all of our listeners, we'd also like to thank the generous support from our listeners who've donated $250 or more to the Jerry Pal podcast, including
Meg Walhagen, Thomas Quinn, Rochelle Bernacki, Louise Aronson, James Tulsky, Arden O'Donnell, Mike Steinman, Marianne Forcia, Ashok Krishnaswamy, Nancy Lundeberg, Gail Cooney, David Schiffling, Cheryl Phillips, Jessica Ng, Harry Hahn, Elizabeth Chung, Kathy Foley, Rochelle Bernacki, Christine Ritchie, and Lloyd Woolstadt. Thank you very much.